Okay, guys, so we are going to start a section here on transitions of care. Can you guys are you guys okay? Can you see me back there? Yeah, okay. Please feel free to move up if you're having trouble seeing us or hearing us. So we're going to talk about a pretty important topic in care coordination. We're going to talk about transitions of care. Does someone just briefly want to tell me the definition of a transition of care?
Hospital to home.
That's an example, yes, moving from hospital to home. Yeah, in the back.
Rehab setting to home.
Rehab setting to home, yeah, that's an example. What's the definition of a care transition or a transition of care? Change from one setting to another. Okay, yes, great. So a care transition is movement of patients from one care setting to another. And I'm sure, as you all recognize, this is an extremely vulnerable time for patients and for their family, support system, caregivers, particularly people with chronic conditions or substance use disorders, and I would also say older patients as well. These are very, very high-risk times where people tend to sort of be between providers and systems, and we can really have a lot of trouble happen in those moments. So, I'm sorry, guys. Believe it or not, I have not coughed really since I've been here last, but I'm going to just grab a cough drop here so I don't cough into the mic. And everyone's like, sure. Okay. Okay. So, poor care coordination increases the chance that patients will suffer one of the biggest problems that we see in terms of transitions of care, and that is problems with medication. I think the number one reason that people are readmitted to the hospital after a hospital discharge is medication issues, right? This is the number one reason people end up back in the hospital. They don't understand what they're taking. They took the wrong thing. They took the stuff they had at home from before the hospital, and they took what they got after the hospital, right? Or they didn't get it. It's at the pharmacy. So medication issues are a huge, huge cause of suffering and cost, and really something that we can help address. Even if you're not a medication person, right? You may be the person who gets someone who can help figure out the medications, right? But it's something we want at the top of our list when we see people transitioning between settings, in particular from hospital to another setting like home or primary care or rehab or whatever it is. And the majority of the reasons that we have problems with medication is our good old friend communication, right? Lack of communication between multiple groups at the hospital, outside of the hospital. And of course, the people who suffer the most, right, on top of everything else, are people who are uninsured, people who are on Medicaid, and people who are on Medicare, right? Statistically, they have more issues with medication issues than privately insured patients. So just some statistics. 17% of adults hospitalized in the previous 2 years reported that information about their care had not been communicated to them. Now, when you see these stats, you think like, well, is that true or is it not? But the bottom line is it actually doesn't really matter. If their perception is that if they leave the hospital, as Yael taught during that whole health literacy section, thinking they don't know what they're doing or nothing was communicated to them, then that's not good, right? So we didn't do a good job communicating to them if we did. Or maybe nothing was communicated to them. This also happens. 27% said that the hospital made no arrangements for follow-up with primary care. Now, this kind of gets into who's responsible for making follow-up with primary care. Is it the hospital? Is it a care coordinator? Is primary care supposed to do it? And I would say, if there's no link, if the hospital doesn't let anyone else know that this person is in the hospital, then the hospital should be making that appointment. But hopefully, ideally, one of you has been contacted, or a primary care office, or people are shaking their heads, or a psychiatrist. So how many people feel that when their patients are hospitalized, they get some sort of notification? Right. Okay, good. This is where you can compete with New York very nicely. Okay, so most people do not get any sort of notice if a patient that you're working with is in the hospital. Is that right? Yeah, go ahead.
I worked in primary care in the Burlington office.
Mm-hmm.
And, I'm pretty sure that all the other primary care offices in the area have a similar program, but we have hospital discharge follow-up protocol where we print out a list 3 days a week of patients discharged from the hospital in the last 3 days.
But how'd you get that? Because you're connected to the hospital, right?
To the hospital.
Yeah, that's it, right? So I have a lot of people in here who are freestanding, right, or not connected to the hospital. Yeah.
I just have a question for the group. Has anybody heard of patient ping? Is anybody using that right now? So that's an event notification software that kind of does push emails and text messages on patients when there's.
What's it called again?
Patient ping.
Patient ping?
Ping.
Ping. Patient ping. Patient ping.
Something that's starting to increase the uptake in the United States.
Okay. All right. So I'm guessing the other way that you might find out if you're not connected to the hospital is you've built relationships with some people at the hospital, right? If you're good at what you do and you don't have anything electronic, you've called up enough times and said, "Hi, it's Carla from such and such. Remember me? Is this nurse so-and-so? Great. Is it possible if one of my patients comes in, you could let me know, or you could fax us, or you could," you've genuinely built those relationships. Do others of you work with, let's say, providers who get notifications?
Yes.
Yes.
Sometimes it is a nurse association. It has a mutual patient-client, and they get notified, and so sometimes they do call me and let me know that someone I'm working with is hospitalized.
Okay, right. All right, so again, it's sort of building this network and trying to build a process so that the process is like, hey, if you hear about this, will you email me or call me or, let nurse so-and-so know who's going to let me know. So just back to these statistics, 67% who were given a new prescription were not told whether to take their other medications. I know you've all seen this. Happens all the time. Happens to privately insured patients too, right? Yeah, and 48% reported receiving no information on medication side effects. So this is a big one, right? Maybe you got the right list, but I don't know, my grandmother-in-law, my husband's grandmother had a heart issue last year, and when she came home, she took all this new medication and it made her dizzy and she felt sick, and they just had no idea. Was that the heart condition? Was that the meds? What's going on? There had been no education around that. And, that caused significant delays because they stopped and they went back and really could have put her life at risk. Yes?
There was an interesting article that I read a while back, and I think it was out of Minnesota, and in the hospitals there, they were actually having a pharmacist come up
Yes.
and speak to the patient before they were discharged.
Yes.
And they decreased their readmission rate by a huge amount just by having this pharmacist go in and check that med list, make sure there weren't any interactions,
Yeah.
and educate the patient about what they were and weren't to take when they left the hospital. And
Yes.
it made a huge impact on their discharge planning.
Yes, and I actually later when I have best practices I'm going to share with you, one of them is if you can, bring in a pharmacist. Obviously I know that depends on what you have available to you, but has shown very, very promising results. Okay, so just to say in the big picture, we're not doing so well. Close to 20% of patients have adverse events in their first 3 weeks home after being in the hospital, 20%. And older patients are particularly at risk of or patients with mental health issues, of making mistakes or misunderstanding their medication, right, and ending up back in the hospital. And a lot of the programs you work in, I'm assuming, part of the big picture goal to reduce cost is about keeping people out of the hospital and reducing readmissions, right? That's like a federal level goal behind care coordination and care management. So this is something we really want to pay attention to. So we're going to do an activity. Let me just explain it to you first, and then we're going to divide you up into different groups. So you have in your packet something that says Transitions of Care Activity. There are 3 scenarios, all related to a patient or a client transitioning out of the hospital back home or to primary care. They're case studies. And what I'd like you guys to do after I divide you into your groups is to create your plan, right? You're the care coordinator. This is your patient, or you just got this patient. You just heard they're in the hospital. What things are jumping out at you that you need to address, that you want to take care of so that this person has a safe transition, a high-quality transition back into the non-hospital setting? And what things will you be following up on? Who will you be calling? What questions will you be asking? And again, maybe you as the care manager or care coordinator can't do everything, but who else are you going to enlist to get involved to make this a high-quality transition of care? So maybe instead of counting them off, I'll just divide them. Okay. Oh, you like moving in? Okay, great. All right. Okay, so I think what I will do is have the back table and this table work together. And your scenario 1, you guys are going to work together your scenario 2. Let's see.
Always transfer you to who it is you're looking for and can give you the extension. Or if you have the person's phone number. Is it a matter of not knowing how to reach them or not hearing back? Not hearing back. Okay.
The right kind of shoes and stuff. So he sounds really uneducated.
Physical therapy.
You know what I mean? Like more education with diabetes would be helpful.
Okay, guys. So we're going to take about one more minute. If you haven't written things down, make sure you write down stuff for your report out, okay? Someone should be taking notes because someone's going to actually report out on what your plan is. Did anyone write anything down? You can put it there. So what we did was we brought your papers up front here. And I know I have one group that doesn't have a paper, so I'll just ask you guys to pick someone to report out from your minds. So who would like to come up and talk to me about their plan for their scenario? Do I have a volunteer, group, or person? Okay, I'm going to just pick then. So someone from the back table, what scenario did you guys have? Is this one of your papers up here?
Yes. No.
You guys are scenario 1. Where's your paper?
Ready.
Is it all the way over here? Okay, we're gonna bring it up. So can someone come up and do a little report out for us? And actually, what I'm going to do is read. Where's your? I need someone's activity sheet. Thank you. I'm going to read this scenario because not everyone did the same scenario, just so you know what you're listening to. All right. So this is case study number 1. Sorry. So we had this. It says one of your health homes patients. That's from New York, right? That's our care management program for Medicaid there. But I know you don't have that here. So we'll just say one of your care management patients, Mr. Jones, is a 65-year-old with COPD, diabetes, and depression. He was recently hospitalized for a foot ulcer that resulted in amputation of his foot. As the care manager, you receive a notice from his insurance company that he is being discharged from the hospital today to a rehab facility for 1 week and then returning home. He takes metformin and insulin, will be leaving on 2 different antibiotics, and uses supplemental oxygen for his COPD. He also takes Zoloft for his depression. He lives with his wife. So tell us what your plan might be.
Well, we had a lot of discussion about different things going on, and I was trying to follow the 5 areas, and we just kind of went all over the place. So, I think the first thing to mention is we talked about all the missing information that we didn't have, that we might have had as a care manager, but we didn't have from the scenario. Some was, you know, what was going on for him, what was going on for his wife, how was the transportation, what was this, so lots of things that would lead into this care plan that if we didn't know, we would need to be talking about and figuring out some meetings to gather that information. We talked about engagement. It seemed like a week in rehab was really short for an amputation, so we were like, let's already talk about the discharge meeting coming at the end of this week now, and who needs to be there and what's happening. Potentially having a meeting with he and his wife to get some of that information that we were missing. And then the VNA order for the home care and treatments. Talked a little bit about, you already mentioned that, you know, work, what is their transportation, do they drive, do they have a car? Looking at the depression, and is he already in treatment? Does he see someone, or is he just getting Zoloft prescribed by the PCP or someone? So again, we're saying we need to get this information. He's coming home with some pain meds, so history of substance abuse or anything to be aware of for that was some of what our conversation was. Pain management was another area we really wanted to focus on. Determine who's communicating the med plan and changes for the client. So again, talked about this great idea of a pharmacist, or who was going to do that. 3 plans: hospital to rehab, rehab to home, and then home to long-term, short-term to long-term care. And the O2, the oxygen that he's on, and mobility, and looking at some of the bigger pictures with that. The flags we mentioned were depression, wound care, pain, diabetes management, making sure all those things were addressed as they were communicated. And we had some nurses or medical people on and said we might encourage extending the rehab stay. That was on our plan. It seemed a little short. Plan for when acute services end. Invite Sash for a long-term picture if he's not already involved. Home assessments, OTPT, transportation. The team we thought would include CP, VNA, CBAA, SASH, mental health treatment. I think that's most of what I've got on here.
Great.
Anything else from my team? Are we forgetting?
How about this? I'm going to actually ask the other group that did scenario 1. Who's that group? Are you guys scenario 1? Can you add anything to this or anything? Thank you very much. Anything that, yes.
We have a speaker?
Yes, great.
Thank you. I would also be checking on any DME equipment going home with them.
Yes.
And making sure that was ordered. And
Yes.
because you only have a week, that's crazy, but anyways.
Crazier things have happened.
And also the follow-up with the MD was made, you know, when they got home. Medication, also instruction with diabetes diet, and
Yes.
making sure that he's, he understands his medication. And,
Yep. So how would you do that? Like, okay, we want him to understand his medication. How would you, you're the coordinator. Who would you get involved? How would you do that? Would you do that? Would someone else do that?
Can I comment on the services before
Yes.
we move forward?
Yeah.
This case, one of the things that we spent time talking about here is that this case should not have been presented to any of us in this stage. Most of the people at the table should have been involved long before this.
Yes.
And it's a good reminder to everybody in the room that there are people who can help so that we don't get cases like this.
Yes.
So that we can be involved.
But so I'll just ask you, does this seem totally, like, completely unrealistic that this could happen, that you could get a case like this? Like, without having been involved before?
it does happen, but then we're way behind the 8 ball, and we're just picking
I get it. This is what we're I mean, obviously I bring you challenging cases here because we're working, right?
Yeah.
But I would also say in a place like New York City, this kind of stuff happens all the time. But I'm just curious if I was off in terms of my guessing here. I mean, Yeah, maybe you know him, maybe you don't. Maybe he just came into the program. Anyway.
Probably, well, diabetic ulcers sort of start smaller and escalate, so he may have lost a toe, or then he may have, lost part of his foot, or it wouldn't just
Pretty extreme.
Wouldn't just, so people might have been involved with wound care and diabetic management before he had an amputation.
Let's hope so, right? But again, we have patients in New York where they live with their wife and they get all the way to an amputation. Like, you would think multiple people would have been involved, and yet the patient didn't come in for whatever reason, or it got this bad. Yeah.
I would also check into like diabetic shoes and see if that's something
Yep.
that you might be interested in,
Yep.
because it would be much safer.
Right.
What else? So most.
Does he
anything else?
mention falls risk?
Yeah, he was a real high fall risk too. With
Definitely.
oxygen tubing around his, his house. He's depressed. With the amputation, he's probably his ambulation's off.
Right. Yes.
So,
I have a question on compliance.
yeah.
Right. Okay, so when we say question his compliance, what are we going to do? What do we really mean?
So, right, so, so is he managing his diabetes? Is he managing his COPD? Was he a smoker? Is that why he has COPD? And is he on board with how, now that he's starting to lose body parts, is he maybe more motivated to change? So
Right,
we need to
or-
assess his motivation more.
Okay, so I might, say, how engaged is he? And maybe put some of that on us, like how good a job has the system done, or the people he's been in contact with been at engaging him? What's really going on with his depression, right? What are the root cause here, that, as you said, things have gotten so bad, right?
The diabetes and depression sort of go hand in hand.
Of course, of course. Other comments? Okay, good, great job. Oh, sorry, yes.
wonder, like, is his wife,
No.
interested in his care? Is she, like,
Yeah,
bring her
Great
to
question.
her, do some training with her?
Yeah.
prior to him leaving,
How engaged is she?
infection Issues, dressing changes, all of that stuff. needs to-
Absolutely. How much does she know? How engaged is she? How much support does she need? What's going on with her? Is she depressed, right? Like, supporting the caregiver, not workforce, but a family member, can help our patient tremendously. Yes.
Especially with nutrition.
I would say especially with everything, honestly, right? Nutrition, but what's her mental health like, and how able to assist is she? Okay, great. Good job. Case study number 1. All right, case study number 2. I think I have 3 groups here. Can I have a volunteer, someone to come up and report out?
I have these two. Am I missing?
Do we have a third scenario too?
Oh, I'm sorry.
Great. Do you want to do the first report out?
Since we forgot.
Yeah.
It's the least we can do.
Yeah. Here,
I'll
we'll hold. Give me this.
I'll hold it up for you. We don't have a lot of surfaces to stick.
So the first thing we talked about was the initial contact.
Oh, sorry. Let me read it,
Sure,
because
yeah.
some people did not do it. So let me just tell you what we're looking at. All right. Case study number 2. Ms. Sanchez is a 25-year-old pregnant woman with a history of anxiety disorder and substance use disorder. She receives care from the primary care provider organization that you work with as a care manager. She was recently hospitalized in a psychiatric unit at the hospital for attempted suicide. She's being released home today and is supposed to follow up with her psychiatrist in 48 hours. She's been given new medication for anxiety and depression and is supposed to follow up with the high-risk prenatal care clinic. She's also been referred to a drug counseling program and is supposed to follow up with them this week. She does not speak with her family, but does have one friend that she trusts. And this is an actual patient of mine when I was a midwife. This scenario actually happened. So I have some thoughts about it.
So yeah, the first thing we talked about was the initial contact. We were hoping that as the care manager we'd be included in the discharge planning meeting, but obviously that doesn't always happen. So if we were able to be part of the discharge planning meeting, we'd like to, promote actually setting up those appointments. She's got 3 people that she needs to follow up with. She's got the psychiatrist, the drug counseling program, and the high-risk prenatal care unit. So either setting up those appointments or at least making sure that she has a written plan with the numbers of the people she needs to call, knowing when to call them and what they're going to be doing for her. If we can provide any assistance in scheduling the appointments for her or at least helping her along that process. If we weren't included in the discharge meeting, that would be either setting up an appointment at the hospital before she leaves or at her home as quickly as possible afterwards to address some of those issues. During that initial visit with her, we'd like to talk about how involved she wants us to be in that process and what she's motivated and capable of doing herself. Along with that, getting consents to release information for anyone that she would like us to be involved with, any of those 3 programs that she needs to get in touch with, and then also the trusted friend. I think it would be, we talked about it being great if the friend could be involved with knowing what's going to be happening in this transition time for her, to provide support for her if she needs people to go to those appointments with her or just be there to help with the medication transition. And then we talked about going over what's important to her, and then just evaluating her home environment, whether her basic needs are being met, food, shelter, her insurance, reviewing that, making sure she's able to go to the appointments and have them covered, making sure she can access transportation to get to those appointments, making sure that her medications are going to be covered under her insurance, and how willing she is to follow the treatment plan that was set up in the discharge meeting. And then we had also talked about, helping her set up a written plan for how she's going to proceed with those things.
Great. Other people who worked on case study 2, would you like to add or?
So we kind of got stuck with it. Well, a lot of us, this is not the group that we normally work with.
I know.
And so we were kind of stuck with, because this is not what we do, that we needed to get the SMART team involved, and we needed to actually find out who was going to be the lead coordinator and then have that person communicate with the rest of the group. So we did not go more into detail, and I think it's because we did not feel qualified.
That's the orange.
It's the orange
I'm
one,
trying to
yes.
hold all 3. I'm failing miserably here.
I'm curious. So I know that on the one hand you don't normally deal with prenatal population. On the other hand, I'm fairly certain that you deal with women of reproductive age population, right? Like anyone, the people see women between the ages of 15 and 45, raise your hand. Any patients? So everyone else has elderly? Or, sorry, so one more time, women between the ages of 15 and 45. So it's about half, right? So my only thought here is that, and I perhaps have a personal, thing from my past, but it always amazes me that we talk about care coordination and care management for women, for anyone, right? And half of your patients might be women of reproductive age, and somehow all the reproductive health issues, like unintended pregnancy, being pregnant, not wanting to be pregnant, like all that stuff, STDs, seems to be totally left out of the care coordination, care management discussion or purview, which is, but you tell me, maybe I'm wrong.
I don't think that it's necessarily left out. I work in our primary care office, and it's just that I wouldn't be the lead care coordinator for that person.
I see.
There's women's wellness, so there's
You have other programs.
workers. So we work together.
Yep.
We have the SMART team in St. Johnsbury. They're fantastic.
Okay.
And they're there for women who are pregnant with substance abuse issues specifically, but there's other people, for any woman who's pregnant that needs support. Home health has programs where they can go in
Right.
and follow the woman throughout the pregnancy, not to 2 years later.
Okay.
So there's a lot of programs, it's just that we're not.
Yeah, right, you're not the lead on it.
I think our group was looking at it more, like, looking at the situation more from each person's own personal perspective and saying, well, in primary care, we wouldn't necessarily coordinate care. We wouldn't be the lead care coordinator for that person.
Right.
But we did talk about making the initial contact with the woman making sure the appointments were made, making sure she has transportation,
Right.
Making sure she got her meds and she understands them, and then figuring out who's going to be the lead care coordinator to follow her, whether it's psychiatry, drug counseling, prenatal clinic, and you know, maybe it's not necessarily who we think makes the most sense, but in order to keep her engaged, who she, you know, so you have her engaged on who's going to be the lead care coordinator, because there's a lot going on with her.
Absolutely, right? So who does she trust the most? Who will she actually call and be in touch with, right? This is someone in crisis who has to get through this pregnancy and then is going to have a child and is going to need help then too. And so who is that person? That's a great call. And yeah, I mean, you may not be the lead care coordinator, but the coordination work is the same, right? Like I didn't do elderly diabetics, but I can certainly imagine and triage through all the different things that someone would need, right? Because the work is similar. Yeah.
Can someone explain what the SMART group is, or the SMART? You guys mentioned it a couple
Yeah, what is that?
Do you remember the name?
I don't remember the
I can't
exact
remember
name.
what it stands for. It's a local team in the St. Johnsbury Health Service area, and there's a health coach there that works very much with women who are pregnant that have substance abuse issues, and they're followed throughout the pregnancy and for a couple of months after before they're transitioned to somebody else.
So there's a national program, it might be part of the national
I think it
program
is.
where there's home visiting programs for women who are pregnant. Some of the programs are for first-time pregnancies, sometimes they can be any pregnancy, and you get a nurse who does a lot of what you guys do, actually. I think it's pretty similar.
Nurse-family partnership.
Nurse
Do you guys have that up there? Nurse-family partnership?
And they do a lot of what you do, and it's for a year, or not a year, it's at least 2 years, and then like different states also have like variations on that.
And they get support with transportation, and there's different incentives for the women to go to their appointments, where they have a bracelet and they get a charm every time they go to their appointment. It's kind of an incentive.
Yeah, that, I mean, again, I think it's a variation on it, but the money might be coming from that, and the research is, you know, similar to this. It improves outcomes, it improves,
So it's
you know,
called SMART?
breastfeeding.
That's what our local one is called, but it is based on
The national program is Nurse-Family Partnership. And the other cool thing is that they don't just help women during the pregnancy. They actually stay with them for at least 2 years after. And they do a lot of things like helping them prepare to be a parent and to helping them, you know, single parent, whatever it is. But it's like, you know, a lot of these programs is like, they help you when you're pregnant, then you have the kid, and like, see you later, right? So this actually helps these women and their families, you know, for that time when their children are small. And the outcomes for the kids later in terms of their education level that they attain and all these other metrics are really very positive. Okay, great job. Did anyone else who worked on case study number 2 want to add anything? I know. Yeah.
We thought that there was probably more information from her that we needed, such as, you know, does she want to keep the child? You know, is adoption something that she should get hooked up with?
Right.
You know, how is her housing? Is that stable?
Right. We don't know a lot of these
So
questions.
just doing a more in-depth assessment was something that we thought we needed to do.
Right. Or what assessment has been done that you don't know about, right? That you'd like to see. Yes.
She's still using, that's the other question.
Is she still using? Yeah, we don't really know. Right.
Because that'll impact her pregnancy and, right, as well as the implications for the child.
Right.
For all later.
Right. It's very sad. Okay. Nice job, group number 2. Thank you. So group number 3, I'm going to. Okay, and then I'm going to read it, and then someone's going to come up. So Mr. Patterson is a 50-year-old veteran with a history of alcohol abuse, bipolar disorder, heart disease, and periods of homelessness. He's one of your patients, and you receive a notification that he's been hospitalized after suffering a heart attack. He has been living in transitional housing. He will now be returning to transitional housing, but also will need to do physical therapy and rehab 3 times a week. He has a brother who lives in another city that he lists as his emergency contact. He is leaving with a list of 7 medications to take. Who would like to come up from group 3? Volunteer from group 3. Don't be shy. Who's group 3? Raise your hands. Jean, come on up.
So we started with, we wanted to develop a patient-centered plan of care, work with the patient as far as who his supports are, who the new providers are, does he have follow-up appointments with them, obviously deal with his meds, what ones are new, does he know what they are, do we need to get a pharmacist involved, or identify all the team players, what else? The transportation, of course, him getting to and from appointments, and of course his willingness to participate with hence the reason for the patient-centered plan of care. What are his objectives? What kinds of things would make him successful with his discharge and his meds? And if he doesn't have transportation, would we start with home care? Would we get a nurse in there to help educate him about his meds if he needs that? Physical therapist to start him with his PT, and then work him into maybe an outpatient cardiac rehab program kind of deal. So sort of start from ground one, see where he's at, and where his caregivers are, and work from there.
Okay, great, thank you. Other scenario 3 people who would like to add anything? Whose group is this? Raise your hand. Hi, do you want to come up? Come on up. I forget your name, but come on up. I know you're.
Well, we're really similar to everything.
Okay. Is there anything that you would add?
I just think that we talked a lot about the first piece being really finding out information about him and identifying caregivers and their roles. We didn't really know, is he getting services from VA? It sounds like there could be so many different players in there.
Right.
So the first thing would be identify caregivers and their roles. Obviously, we have to establish a care coordinator to address all the issues that we talked about: med management, PT, mental health, identifying medical, social, and client goals. Like, what does this patient want to achieve? We were talking about, sometimes people just want to reduce treatment. He doesn't want to do cardiac rehab. What are his goals? Communication, clear chain of communication, and I think that's it. I think everything else was touched on the other group.
So did anyone think about maybe being in touch with his brother?
Yes, we did mention.
You did, you said that, yes.
I think we forgot it, but we were talking about identifying someone closer, maybe if there was a friend or someone, finding out from him if there were other people that we could get on board with us.
Right. Yes.
Also, I'm just thinking too, just now that, I think with a patient with this scenario, he's been so transient, all that period of homelessness, so that in some ways his being sick in this unfortunate scenario could actually, with the right, him being, interested in prioritizing his wanting to make this a priority of getting better, but also having the right connections and maybe reconnecting with his brother, that he can then actually get the supports that he hasn't had. So it could sometimes, occasionally, it turn into a positive.
Absolutely.
But I think it's, I don't know, it all really depends on him wanting to participate in his care.
Absolutely. I was going to say the same thing, right? Sometimes something bad happening is the moment where people are able to make a change, or they're open to it, or they almost die, and then they perhaps think about their life differently. And I think there's a lot of statistics that this is out of the Camden Coalition, but they show that for people who have traditionally been kind of resistant or not open to care or help, if you meet them in the hospital, that's usually the best time to get them engaged, right? It's very real that they're sick and they're most open to receiving some help. So I would agree with that. Anything else anyone would want to add to this? Okay, well, good job. Case study number 3. You guys did a great job.